Hello YouTube, this is Mark Hill and I am the Traveling NP. I've been out of pocket for a little while. I had some unfortunate things happen to me physically. About 15 years ago I was diagnosed with colorectal cancer, and I had my rectum and sigmoid and about a foot of my descending colon removed, and had a colostomy placed that I have managed for the last 15 years. Well, I developed a peristomal hernia over the years, which is not uncommon with a colostomy placement. And I've had it for years, and even attempted to have it repaired at one point about 8 years ago, and it didn't work very well. So the peristomal hernia, persisted for all these many years, and I had gone to take an assignment the middle of January. I was leaving the 13th, flying out on a Sunday, and I started having severe abdominal pain, and I went ahead and felt like maybe it was just a little stomach virus or something. I wasn't sure what was going on, but I went ahead and got on the plane, and about halfway from Jackson, Mississippi to Atlanta, I started vomiting on the plane, of course, which was very uncomfortable for everyone. And got to Atlanta, and I knew by that point the pain was very intense, and I was coming close to passing out. And so I called the company that I'm working for now full time and told them that something was wrong, and so I was not going to be able to make my assignment, which was kind of put them in a bind, but there was really nothing I could do about it. I was severely ill, so they had to cover me for a week, 7 24-hour shifts. And so I flew back, caught the next plane back to Jackson, and when I got off the plane, I told my wife, take me to the nearest emergency room. Making a long story short, got to the emergency room, they scanned my belly, and I had an incarcerated hernia with bowel obstruction, of course, and had to have surgery. So they went in, they had to do an open laparotomy, and they removed about 2.5 feet of my small bowel and about 6 inches of my large bowel. And while they were in there, they took out a whole bunch of mesh that had been placed prior to surgery. And basically, the surgeon said it was a gigantic mess inside my abdomen. It took him 4.5 hours to reconstruct everything, go through all my bowel loops, and put it all back together. And then he reapproximated my colostomy about 3 or 4 inches higher and closed up the old one to correct the peristomal hernia. And in the process, he also took out my appendix. So then I was released from the hospital 4 days later. I was doing great. So I was up walking, taking a full liquid diet. And I was home for 2 weeks, almost 2 weeks. And then I got an ileus. And so then I found myself right back in the hospital with another NG tube and IV fluids, very sick, very dehydrated, and spent another 3 days in the hospital, and then just got out about 4 days ago. But feeling much better now, feeling like I'm getting back to normal, feeling a sense of that things are normalizing, but I have been very ill up until this point. Lost a lot of weight, so yeah, it's been tough, but just a little update of what's been going on with me. One advantage, I guess, to locums is that don't have a full-time job, so I'm not putting anybody out. The disadvantage is I'm not really making any money in locums because I'm not working. Now, the upside of that is I got the telemed. And I was laying in the bed in the hospital the day after my surgery with an NG tube down my nose. I was doing telemedicine. So the day after surgery, I made $700 laying in my hospital bed. So multiple revenue streams is the key. You got to keep going. Now, that doesn't have anything to do with the topic I wanted to explore today. Today, I wanted to expand my horizons a little bit with what I'm doing on this YouTube. As most of you know, I don't make any money off this YouTube channel. I've got close to 300. I guess it's about 270 subscribers, and pretty solid, base of people who are interested in this type of business. And I have gone over every, possible subject that I think I can until I come up with some new ones when it comes to locums or telemedicine. So I was wanting to expand my horizons a little bit, and one of the things I wanted to talk about today was the term mid-level and the future of the nurse practitioners and physician's assistants over the next 15 to 20 years. First of all, I hate the term mid-level. I think it's a very degrading term. Very few physicians use it now because most of them know that it's a degrading term. And when somebody calls me mid-level, I always think in the back of my mind now, mid-level. Mid-level insinuates that I am supplying mid-level care. Well, I would like to ask the 10 people whose lives I personally saved over the last 2 months, either through intubation or through other emergency corrections of their metabolic disease processes, if they feel like that my care was just mid-level. Ask the 2 ladies that I intubated last month. Ask the lady that came in with the metabolic acidosis of 6.9, who was on the brink of death, who is now living and breathing and back home. If she felt like that my care was mid-level. And I bet you that the answer would be no. That they feel like that their care was exceptional. I hate that term. Mid-level to me is a very degrading term. I've worked very, very hard to get my knowledge base to the point where I feel like I can handle myself very well in the emergency room setting and even in the primary care setting. Now, do I know everything? Absolutely not. And there is no one who does. But I can tell you this. I have worked with nurse practitioners, PAs, MDs, and just because you have certain initials behind your name and you have certain training that you've done over a period of time, it does not make you a good clinician or a good provider. It just does not. Self-study, and a commitment, a personal commitment, and the pursuit of excellence makes you a good clinician. Mid-level is just a derogatory term, and I absolutely hate it. I do not feel like in any way, shape, form, or fashion that I am supplying mid-level care to my patients. If I truly felt like I was only supplying mid-level care to my patients, I wouldn't do this. So, anyway, let me move on from that. Where do I see the future of the nurse practitioner and the PAs in this country? Well, frankly, I've seen it evolve very drastically over the last 20 years. I can remember, 20 years ago when I was a relatively new nurse, hearing about nurse practitioners who were going to school, very few of them back then, who were functioning similar to that of the primary care physician. And what's happened over the last 20 years is that the nurse practitioners and the PAs of the world are now beginning to take over certain aspects of the primary care field. We are really beginning to function similar to the old family doctors who used to live in all these little towns, Dr. So and so, they used to take care of me when I was a kid, or, you hear all the stories that your mom and dad used to tell you about, oh, we love Dr. So and so. Well, the nurse practitioner and the PAs, they are filling that gap. Because what's happened is that doctors no longer want to do that anymore. There's no money in it for them anymore. They have really started specializing and going into fields where they can maximize their financial potential. Now, there's nothing wrong with that, but what's happened is it's left this gaping hole in the primary care field and in another field in the emergency room field. Because emergency room physicians now, some of them are commanding $200 an hour for their services, which in a 12-hour shift is $2,400. Well, these little critical access hospitals, small hospitals, 6-bed, even 10-bed hospitals, they can't afford that kind of thing. They don't have the volume to support that. And so what you'll find in the great northern Midwest and in other parts of the country is the nurse practitioners and the PAs are beginning to fill those gaps. They are beginning to train specifically, like I have, to work in the emergency room, to handle emergency cases, oftentimes to stabilize and transfer. But I also do a lot of inpatient too. A lot of the hospitals that I work at, when I admit a patient, I admit them, and then I have to do the inpatient care of that patient as well. So depending upon the severity of the disease process and the stability of the patient determines on whether or not I admit that patient to myself and take care of that patient in the hospital. So a lot of times I'll admit a patient on Monday for congestive heart failure, pneumonia, or cellulitis, or whatever I'm going to be treating them for, and I may do that admission, see them in the ER, do that admission, see them every day in the hospital, and then discharge them 3 or 4 or 5 days later. And they don't see anybody but me, which goes back to the whole mid-level question, right? So you're in the hospital and you're only receiving mid-level care from start to finish. Anyway, so what's happened is that you're finding that MDs don't want to go out to these small areas. They don't want to go to these small places where there's not enough money for them. They've got big student loans to pay off. They've got a lot of time invested. But you know what? So do I. I've got a lot of time invested. I've got 7 years invested in my education. Not to mention 20 years of experience prior to that. I was a critical care nurse and ER nurse for 20 plus years before I ever went back to nurse practitioner school. And so I'm reaping some financial benefits too. But all in all, a nurse practitioner can come out and work in these emergency departments for half the cost, and in some cases less than half the cost of these MDs. And so it's becoming a significantly used resource in the rural communities. There's a lot of training and a lot of things that go into a nurse practitioner being prepared for the emergency room setting. And, really you need to have your skills up to par. You need to have your nerves checked. You're the man. A lot of these places I work, when I check on and I sign on and I punch in, so to speak, I may be the only provider within a 50, 75-mile radius. There is nobody else. There's nobody to come help me, nobody to rescue me. I'm it. So, there's a big need for that. It's all over the place. You go in the Midwest and up where I work, North Dakota, Montana, Minnesota, South Dakota, Iowa, it's just a huge need for nurse practitioners like that. So over time, we have begun to take over a lot of aspects of healthcare because we're efficient, we're smart, we're skilled, we have good educations, and we are cost effective. I feel like that the sky is pretty much the limit at this point. we eventually nurse practitioner graduation rates are going to slow down as it becomes mandatory that it's a doctorate prepared program, which I think is going to hurt patient care in the short term. But I don't think that they're going to change those requirements for a while, because there is such a need still for nurse practitioners, because there is such a doctor shortage, especially in primary care, psychiatry. I mean, if you want to make a ton of money as a nurse practitioner, go be a psych NP. There's jobs everywhere. You can sit at home, sit in front of your computer, and make $150 an hour as a psych NP. The future is very bright. I won't ever experience the pinnacle of the nurse practitioner rise because I'm too old. I'm 52. I figure I've got another 10 or 15 years left in me, and then I'll retire. But hopefully by that point I will have made my money and done what I need to do to be financially successful and set myself up, which I'm in the process of doing. So what I would do if I was a new nurse thinking about being a nurse practitioner is I would look at being a nurse practitioner, even as a new nurse practitioner. Look at being a nurse practitioner as an avenue of success that is going to have huge benefits in the future. We are going to continue to expand. Our roles are going to continue to expand as we deliver babies, as we work as sole providers in emergency rooms, as we own our own clinics, as we run our own clinics. Now you'll find that some of these critical access hospitals that I work at, they don't even have a MD on staff anywhere in the hospital. They have a medical doctor that comes in once a week and functions as the chief of staff, and he comes in once a week and kind of signs whatever, and a lot of times they'll round in the nursing home, but there are no MDs on staff. They're there for about half a morning. I know one hospital I work at, they're there for about half a morning on Thursdays, and that's it. And they're gone. You don't see them again until next Thursday. And then there are no MDs in the hospital after that. So the entire system is run by nurse practitioners or PAs. Now, a lot of these critical access hospitals don't want PAs because they don't want, in states that are autonomous, because they don't want to have to hire an MD to sign behind them. So most of the states I work at, well, actually all the states I work at, have nurse practitioner autonomy, and so you'll find that they're dominated by nurse practitioners because you don't have to have an MD coming behind you and signing your charts. So that helps them out and saves them money as well. So the future of being a nurse practitioner or being a PA is bright. Don't get the impression that it's going to be oversaturated anytime soon, because it's not. And there's always going to be a place for a highly skilled nurse practitioner. And another thing too, just because you're a nurse practitioner doesn't mean you're a good clinician. Okay? There are a lot of good nurse practitioners out there, but there's a lot of bad nurse practitioners out there too. Just like there's a lot of good MDs out there, there's a lot of bad MDs out there. There's a lot of good lawyers. Well, maybe not. There's a lot of good cops, and there's a lot of bad cops, or some bad cops. There's a lot of good and bad in every profession. The truth is, it's up to you as to whether or not you're going to be good or bad. It's really a choice. And you have to decide how much energy you want to put into your profession. Anyway, this is Mark Hill. I'm glad to be back. I'm feeling better, feeling good, moving on with life. If you have any questions, let me know. The Traveling NP. Talk to you later.